We're now going to learn a little bit more about the other cornerstone of preventing cardiovascular and so many other diseases, which is exercise. And I've been coming here on the organizing committee for about 6 or 7 years now, and I've heard Dr. Paulo's talk many times, and he's certainly taught me a lot about the science behind exercise and how to apply what we know about exercise. But I think more than that, I always come away from hearing Paul speak, I always feel inspired and regenerated to go back to my practice and put more emphasis on exercise. And I'm really pleased to see that he's brought 2 other members of the team. I think, correct me if I'm wrong, but some associates from the Toronto Rehab Center and also from UHN, who are both registered kinesiologists. We have Susan Marzolini, who has a PhD in medical science from U of T. She is an associate at Toronto Rehab University Health Network. She has extensive experience in cardiac rehab, and currently she's a coordinator and case manager, and her interest academically is the dose-response relationship between exercise and health-related outcomes. We also have Danielle Lawrence, also a registered kinesiologist, a research associate, and cardiac rehab supervisor at UHN Cardiovascular and Prevention. And I'm delighted to introduce the team here, and we'll hear what they have to say about exercise. Over to you, Paul.
Thanks very much, Chris, and it is indeed a pleasure to be here. So you will entertain yourselves with lunch. I will entertain you with being enthusiastic as best as I can. We are delighted to have the main stage. We've grown up, Chris, and graduated to the big stage, and as a result, as you've said, I brought friends with me who are even more knowledgeable than I. So this is us, the group that will be presenting. My disclosure is that I do hold a research chair through our hospital foundation, Peter Munn Cardiac Center, that is funded by Good Life Fitness. You may perceive that as a conflict, which I agree with. However, I will tell you shamelessly, I think exercise is a good thing. I'm happy for you to do it here. I'm happy for you to do it outside. You can do it at a club. You can do it at home. Do it anywhere. Just do it, okay? We're not going to talk about any clubs in particular. We're also not going to really talk about medications either, for a change, and I think that builds on a theme that has been expressed throughout the entire morning and probably conference. We're going to be talking about specifically, so while you are dining on a heart-healthy lunch, I'm going to do a little bit of review about the proven benefits of exercise. You all believe that it's probably a good idea. We'll address a couple of questions and update what's new in the literature over the last year or so around how much do we actually need? Pose the question, is this actually might be a bad thing? Is exercise indeed hazardous? We'll move into a second part that Susan Marzolini will lead on exercise and benefits with stroke, because that's been her real focus area for her in the last few years, and she's done outstanding work in that area. We'll talk about resistance exercise and pose the question, can you join a band? I think you've all gotten a red exercise band. If you don't have one, they're available at the back from our wonderful Heart&Stroke team. Lisa's holding up some. And if, in particular, many of these bands you may know are actually made out of latex. And if you need a latex-free band, those are also available, special ones in the back. And Lisa reminds us that these are yours to take away, to take home, because we'd love for all of you to be using this on a daily basis from here on forward, and we're going to give you the tools on how you can actually do that in an effective manner. And then finally, if there is any time left after all of that, we invite all of you to be able to write an exercise prescription starting on Monday when you get back to your clinics. And Chris has done that. I know he has, and hopefully all of us will be doing that as well. So how's that for an agenda? I'm exhausted already. Thank you for coming out, and have a good day. So let's start about the State of the Union. And we heard from the morning sessions that there perhaps are gaps in what we are doing versus where we want to be. And Dr. Morrison, I think in particular, said, here's some data. She introduced the topic, but said there's some data coming. So here's some data. If we actually look at Canadians who respond to a heart health survey, for instance, across the country, and quantify objectively what is the state of the union. So the left side bars, the pink are women, blue are men, not trying to be sexist in any way, but just trying to differentiate the two groups distinctly. you will see that the average Canadian adult, as well as kid that we heard about this morning, spends about 10 hours of their day in a sedentary state. We'll talk more about why that might be a bad thing, but that's kind of the state. About 200 minutes per day in light, and then about 20 minutes per day doing moderate to vigorous activity. And some of you might say, well, that's actually not too bad because our target's 30, so they're getting 20 out of 30, so maybe that's not so bad. But the key thing here I want to say is 10 hours sedentary, which doesn't sound so good, because I'm going to talk about the 20 minutes in a second. Because if we actually dive further into that 20 minutes of moderate to vigorous physical activity and quantify that even further, we can ask these Canadians and measure how many people actually get in a kind of a reasonable sort of threshold of 10,000 steps per day. And that's about 35% of people. Subdivide this even further by saying, do you get, of those steps, how many are purposeful and moderate to vigorous in bouts of at least 10 minutes? So if you're going to go out and walk at a brisk pace, try to get at least 10 minutes, because then you can actually start to jazz up your cardiovascular system. Well, now we're down to about 15% of Canadians. And if we ask the question, are you getting 30 minutes per day in bouts of at least 10 minutes, moderate to vigorous, on at least 5 out of 7 days per week, that number unfortunately drops to about 5% of Canadians. So the State of the Union, on the one hand, looked maybe not so bad. When we actually quantify it discretely, objectively, it looks like there is an opportunity. So being an eternal optimist, I would say, well, this is great data, isn't it? It's great data because 95% of Canadians need you to talk about exercise and physical activity. That's virtually everybody that you're going to see. It doesn't matter who's walking into your office for whatever condition. This applies to everybody walking in. That's a good call to action to say, this is worth bringing up and discussing in terms of almost every encounter that we achieve. The majority of Canadians don't get enough, and we are part of the solution because almost all Canadians will come to one of our locations in this coming year where we have this opportunity to really change lives. Call to action. So, if I pose this question to you, what level of weekly moderate to vigorous physical activity is associated with optimal CV benefit? And let's do a show of hands since I don't have the audience response system keyed up. Who would vote for 75 minutes per week? That's 15 minutes a day. Who would vote for that? How about 150 minutes per week? That's 30 minutes a day. You're voting for that. You're good Canadian physical activity guidelines people. How about 300 minutes per week? Were you swayed by the obesity talks this morning, Dr. Hamdi? And how about more than 300 minutes per week? Anybody want to vote for that? So I think majority have voted for 150 to 300, but we have votes on either end. The great thing about one of these questions is you are all correct. Some of you are a little bit more correct than others, but you are all correct. And let's explore some of this data if we can. So this slide I may have shown to you in a previous meeting. This is a compendium, a compilation of about 300,000 patient years of experience that looks at the relationship of heart disease versus the number of minutes of moderate activity per week or caloric expenditure. And there's this curvilinear relationship that says that at 75 minutes per week, we can enjoy about a 7% reduction in cardiovascular events. At 30 minutes per day, about a 14% reduction, 150 minutes per week. And then out to 300, that I think the majority of you have started voting for, then we'll get to about a 20% reduction. And then the curve kind of flattens out thereafter. That is, more activity may offer some benefits in other aspects of health, but our cardiovascular benefit kind of plateaus. So you don't necessarily have to go out and work incredibly hard every single day. And indeed, we might wonder, is there some cautions that we might put up there? In the heart arena, a very topical sort of topic, Dr. Hegley, for those of you here, started showing you some angiograms and atherosclerotic plaque, that there is something about dose response. And if in this interesting German study that was published a while ago, the reason I like bringing this up again, it talks about the dose response. We talk about dose response of medications. Here's a dose response of exercise on top of all the other things that we can do. And if we take people and angio 100 men and find moderate coronary lesions, we can look at what happens to them over the course of the next year according to randomization to different physical activity levels. If people do the plan that you are all thinking about, 30 to 60 minutes per day, that you can actually see stabilization of these lesions over the course of the next year. Outstanding. If they happen to do less than that, which is the tendency for most Canadians, as we've seen from data, that unfortunately we see progression of these lesions. The magic happens, though, in this German environment. If you are a caring German cardiologist, and go TFC, go win, and if you're a caring German cardiologist, you will cycle and also play football with these patients 90 minutes per day, you may actually start to see regression of these lesions. So we can offer statins, we can offer PCSK9 inhibitors, but we can also offer a dose of exercise in a purposeful way to improve people's hearts. But the question we might ask is this always a good thing, and might there be some hazards? What is there about dose response? So new literature that actually helps us down this road, it looks like this sort of thing, that 65,000 people that are in normal sinus rhythm, for instance, and we can look over the course of the next 5 years. Colleagues in Detroit looked at this in their stress testing population, and they found that there was this interesting, clear relationship. The fitter you are, you can improve bad things from happening, like developing atrial fibrillation, which we know is a tendency for all of us as we get older. Fitness can protect against that, which is an exciting phenomenon. We know from our own work, and Dr. Kavanaugh, who is the founder of our rehab center and really changed this notion of fitness and survival in heart disease, he showed us that independent of all those other important risk factors that we can look at, if you look at fitness in particular and look over the course of 25 years of follow-up, those who are fit survive better than those who are unfit. This is a really important modifiable risk for us. So it's worth paying attention to. But the second question I might pose to you is this just a blanket thing? More is better, let's just keep pushing this? Or is indeed exercise potentially hazardous? Because every marathon season that comes upon us, we see these headlines in the Star or the Globe and Mail, and then this is a sampling of visual images. So, poll of the audience, does anybody think exercise might actually be hazardous to your health? Does anybody think so? So a few of you are saying yes, about a third of you, and you might be supported by lovely headlines like this, right? Runner dies after London Marathon. Endurance exercise actually kills you. Triathlete dies of a heart attack. Soldier collapses. So there might be something to this, absolutely. What does the data actually tell us? So if we look at high-level exercise performers, marathoners, half marathoners, and look at the data. So this was a publication from the New England Journal from a couple of years ago. Looked at 10 million runners that had been doing halves or full marathons. And indeed, there were about 60 cases of cardiac arrest that occurred in the setting of those marathons. Gosh, marathons must be really, really scaring because they're killing people, aren't they? And the autopsies would show that these people had a hypertrophic obstructive cardiomyopathy. Some actually had underlying coronary disease. This was a scary thing. Right? So that's what grabs headlines, to say exercise might be dangerous. We need to put this in context, though, don't we, right? Because if we look at 10 million other Americans within the course of a year, there's about 16,000 cases of sudden cardiac death that would occur. So of the running community, 60 people had cardiac arrest. Of the non-running community, 16,000 of them had a bad cardiac event. So let's just put those things in context. Exercise may be a bad thing for some individuals, and exercising at a very high level in particular may be hazardous, but this is trumped hugely by people that don't exercise. That's the real scary part here. But maybe there's something to this dose response thing. So let's go across the globe to Copenhagen and look at runners in that city at a wider range. Not only the marathoners, but let's just look at day-to-day warriors, day-to-day healthy joggers, and compare to non-healthy joggers that are followed over 14 years of time or so. So they looked at interesting dose-response comparisons and would suggest that, indeed, maybe if you did too much, that's a bad thing. Certainly if you didn't do enough, that was a really, really bad thing. And if you had to look in the middle, that the optimal time spent jogging might be 1 to 2.5 hours per week. So that's 60 to 150 minutes that many of you endorsed. And the optimal frequency is not necessarily every day, but 2 to 3 times per week. And you don't have to run fast. You just have to run or jog or walk briskly, because average paces are probably the best paces in terms of longevity for heart disease. Going further into the atrial fibrillation literature as another model, this study looked at 4,400 men who were free of atrial fibrillation and looked over the next several years over what happened to them. Indeed, again, walking or cycling is better than not doing anything at all. But of those who are active, doing a whole lot of activity, like more than 5 hours per week, training up for the ultra marathons, may be associated with excessive risk of developing atrial fibrillation as well. All right? Further, this study, particularly in people with coronary heart disease over 10 years, that was published a couple years ago, this is kind of the summative slide on this, that if people don't exercise with heart disease, they've got a very high risk of mortality. If you do some level of activity, this is clearly better. And then the optimization point, 2, 3, 4, 5 times per week, you're going to enjoy the best benefit of all. So do some, not too much, not too little, just right. And that's what's in my head. What our smart exercise physiologists have taught me is think of that Goldilocks principle. Not too much, not too little, just right. And that's especially applicable to the heart population. And we know if we do this extremely well, thinking about evidence-based therapies, in our world of rehabilitation, working with people recovering from heart attack, stroke, surgery, living with AFib, living with heart failure, that collectively that we can offer an intervention, this is the power in your hands, that we can reduce mortality, other bad things from happening by about 20%, all-cause mortality by these programs. This is not a nice thing to do. This is a must thing to do. It raises that call to action, that priority, that this is money on the table. And unfortunately, like most Canadians, people living with heart disease ain't getting enough. So this is something that we really can work on. Okay, a couple of other concepts quickly. Let me turn to a bedtime fable that we're all familiar with. Aesop told us about the tortoise and the hare. How does that link with heart disease at all? Where the heck is he going now? But let me pose you this question. You never get these questions on a maintenance of competency exam. So I will pose this question in the context of exercise. Who is right? The hare, who wants you to run rapidly, start, stop, scurry all over the place, or the tortoise, slow and steady will win the race? Who is right? Vote for the tortoise, slow and steady, that's what the fable told us, or the hare, scurry about. So 3 of you have said, let's go with the hare. Most of you voted for the tortoise. Let's see, with respect to exercise, can we shake up our models? Because indeed, most of our cardiac models are indeed around the tortoise. Let's go slow and steady and continuous. Let's not change up the system too much. But maybe we do need to change it up a little bit and shake it. This is not what we're talking about. We're all heard of the HIIT, right? And some of you belong to the urban jungle gyms, right? Where you're throwing around kettlebells and lifting tires and doing these sorts of things. That's not what we want the people with heart disease to do. The last guy that I met who did this came to us after having a sudden cardiac arrest. So it happens, and that's not what we're talking about. What we are talking about, though, are an increasing body of literature that talks about doing interval kinds of training with people with heart disease. The notion that you can go faster and then a little bit slower, a little bit faster, a little bit slower. But you can see in this model, colleagues at the Henry Ford Health System published this study where they're taking people at moderate intensity, like a heart rate of 100, up to peaks at a heart rate of 115, back and forth. This ain't flipping truck tires. This is going a little bit slower or faster on a treadmill, and you can see how happy this guy is while he's doing it. Susan is doing actually very leading research in this area in stroke, and I think may tell you a little bit more about that. But that's what we're talking about, this kind of intensity training. And indeed, in a number of studies that have been done in coronary disease, by doing these ups and downs in terms of activity, we can actually push that fitness equation much, much more than we might with that moderate continuous model. So hares are actually doing better than tortoises with the right kinds of selection of individuals, and they're having more fun doing it, much as you might be having doing that as well. Even for people with grade 4 hearts and ejection fractions of 15%, who we might be afraid of exercising, actually, if you put them through interval training kinds of models, so compared to no exercise, which is shown at the top, endothelial function, vascular relaxation, people that don't exercise, they don't get better. That's no surprise. Their fitness, their maximal oxygen uptake does not get better. If you do moderate training with them, they get some improvement in vascular function, small gains in fitness, but at the bottom, if you do aerobic interval training, ups and downs in their exercise program, they actually gain quite a lot in terms of vascular relaxation, better vascular function, and they gain quite a lot in their fitness levels as well. So this poses questions to us that maybe we could be doing things a little bit differently. So 150 minutes, aerobic, let's do the right kinds of frequency, but maybe we start to shake things up a little bit. And in atrial fibrillation as one other kind of model, so maybe we're actually really scared of exercising these guys, but actually, given the kind of person who has AFib, who has typically a high BMI, hypertension, dyslipidemia, diabetes, sleep apnea, the important therapy beyond the radioablations or the dangerous drugs that we offer them is actually exercise programming. And this is one way of actually changing the system, pushing the system further, that might actually gain better control of their AFib than not. I don't know if anybody's thought about doing that with your AFibers, but that's actually really, really important. And long-term studies from Australian colleagues show that over a period of 5 years, those who exercise more and gain a better level of fitness, that's what's shown in the blue, the red line, versus the typical person who lives with AFib, who takes their drugs and anticoagulants, they get a lot of AFib recurring. People who actually pay attention to their lifestyle and exercise can actually remain in sinus rhythm much, much better. Okay? So, that hair might be onto something. So for the 3 of you in the room that already moved to the hair, maybe some of you will attract your colleagues and start to pull on the tortoises, right? We start with tortoise programs, but maybe we actually become the rabbit as we move along for some of these individuals. I'm going to finish up with this kind of case. So what is the most dangerous part of this image? And I pose that because we started this morning talking a lot about obesity, weight control. So if you would vote with me, what's the most dangerous image here? Because hopefully you're all alarmed at this picture. But what is really alarming you? Is it this guy's belly? Is it the fact that he's a man? Is it the fact that he's got this weapon of mass destruction called a remote control? Or is it the fact that he's on a couch that's really scary to you? And only 5 of you voted this time. So we could say if we look at traditional risk factors, all of them are important, but of course, you know where I'm going with this, that the most dangerous part of this image is in fact the idea that he's on a couch. You've all heard this story of double-decker buses. Just quickly, that story is lovely just to set this up, right? So double-decker bus is a wonderful place to do a medical experiment if you're in the UK in 1950. Because on the bus, there are 2 blokes that work there. The guy that drives the bus and the bloke, who stamps your tickets all the time, all day long, right? The difference between them, because they come from the same locale, they drink the same things, they eat the same things, they may be married to the same people, but the only difference between them is one drives the bus all day long sitting, and the other guy runs up and down stairs all day long. Wonderful natural medical experiment that would say, let's look at coronary events in these 2 populations. You would predict, and indeed that's what was found by Sir Jeremy Morris, that people who drive, sit on their bums all day long, have 3 to 4-fold higher risk of heart attacks than the people that run around stamping tickets all day long. Sedentariness will cause heart attacks because everything else was controlled in this population, which was very, very interesting. It's led us to think that indeed, there's a large body of literature that looks at sedentary behavior. This was one paper that we published last year that talked about a 50% increase in cardiovascular disease by sitting, doubling of diabetes risk by sitting, doubling cancer risk, and increasing your risk of death as well. We talked about screens this morning, and this analysis of American retired people looked at the risk of screens. 7 hours per day of TV time doubles your risk of cardiovascular mortality. And it doesn't matter if you're very active, that that 7 on the left-hand panel are people that do 7 hours of exercise per week versus the people that never do exercise on the right-hand side. So people who exercise have a lower overall risk, but still screen time doubles your risk regardless of the category. So we think of them independently. Exercise, sedentary time. Need to get both and think about both sides of those equations. And that's how physical activity counseling is kind of evolving. You can't get around screens. We know that everybody's committed to them. So we might just change our relationship with the screen. At previous meetings we've talked about, for instance, television time is fantastic if you embrace the commercial. If you embrace the commercial as an opportunity to get up and march around. In every hour of television time, there's only 44 minutes of programming. 16 minutes is devoted to commercial time. If you march for 16 minutes every hour through the course of an evening, you've got 30 minutes of marching on the spot, just doing this in a commercial. You get your 30 minutes a day just by doing that if you embrace the commercial, because you're not getting rid of your screens, right? And then all of you can think of more interesting things to do during TV time, including doing band exercises. Why? Because humans have evolved spectacularly. We have perfected what we're doing right now. We have perfected the art of sitting. And if we put on accelerometers and EMG on you, you can see that act of sitting is associated with 0 muscular contraction. We are so good at this. Then contrast that to standing. While we try to stand still, there's actually a great deal of activation in the purpose of standing upright. We have to correct ourselves all the time. And we actually activate metabolism by doing so. So where are you on this curve right now? It is now T plus 30 minutes post-meal, and your glucose curves are starting to change. If you had, in this experiment, colleagues in the UK did this one, where they took 20 office workers, simply randomized them to 1 week of sitting in their office desk versus standing for 4 hours of the day. The people who actually got to stand 4 hours of the day had a 40% lower glucose excursion post-meal, post-standard meal. That's what's in our power, and that's why we thank you for signing your waiver that you did this morning, that you agreed to do something very dangerous by attending this conference and sit on your bum. So that's very dangerous. Look at that, okay? Can you feel the constriction in your artery right now? Can you feel the glucose floating around freely? The free fatty acids, it's lovely. And we would pose then that every time people do an exercise program, they would get a warning, right? Don't do this yoga program without consulting your doctor. That's what they would find. You pull up something on the internet. We would pose instead that the most dangerous place in the house is the couch. And there should be labeling of these couches. Call to action. Consult with a medical professional before you use this thing, because this is going to kill you. All right? The yoga tape's quite fine. Thank you very much. So that's 30 minutes. It's definitely time for a stretch, isn't it? So let's invite you to stand. This is 1 minute. 1 minute stretch. So we all sit, we all get crunched over. So let's move around our necks. Take your head, move it to your left side, hold for 5. Take your head, move it to the right side, hold for 5. Take your head, move it forward for 5. And take it to the back for 5. And start doing a couple circles to the right, circles to the left. Doesn't that feel much better? We tend to get crunched over in our day, right? So try to crunch over. Bring your back, bend it over, become like a turtle. And instead do the opposite now. Let's open it up. And this is what we need a whole lot more of, right? Expansion of chest, expansion of those muscles. All right, give yourselves a hand. Thanks for doing that. Thank you for saving your own lives right now. You've countered all that glucose thing. It's my pleasure at this point to introduce my good colleague, Susan Marzolini, to take us through exercise and stroke. Thanks, Susan.
Thank you, Paul. As Paul mentioned, I'm going to be talking to you about Toronto Rehab UHN's risk factor modification and exercise program for people following strokes, also known as the TRI REPS program. And we started this program 13 years ago as a substream of the traditional cardiac rehab program. We started it in part because we were receiving an increasing number of referrals for people with coexisting coronary artery disease and stroke with mobility deficits. And it was a challenge to fit them into our traditional cardiac rehab program. We also started it because we wanted to fill a gap in the care of stroke survivors with no diagnosed coronary artery disease, because at that time, we were the only medically supervised risk factor modification and exercise program for people with stroke with deficits. And despite the importance of these types of programs, they're still not widely available. So that means that most of the 400,000 Canadians living with a stroke have never had access to exercise training programming. And it's critical that we improve access because there are 50,000 strokes occurring in Canada every year. And a quarter to a third of these are recurrent strokes. And because we now have compelling evidence that regular physical activity will play a role in the secondary prevention of stroke and comorbid coronary artery disease, we know that we can prevent some of these repeat strokes. And this is especially important in view of the recent report in the journal Stroke that in the next 2 decades, the number of Canadians living with disability post-stroke will increase by 80%. Not only will exercise training help to prevent strokes and mortality, but a program of aerobic and resistance training will help to control and even reverse some of the effects of a stroke that affect a patient's quality of life. And I'm going to describe those briefly. So despite improved acute medical management, only about 14% of individuals who survive a stroke will achieve complete recovery. So that means that most patients will be left with hemiparesis, muscle weakness, and ambulatory restrictions. And that can significantly affect their independence and their participation in the community. The level of cardiovascular fitness falls just at or below that required for independent living. So that, combined with ambulatory restrictions, can prevent people from crossing an intersection before the light turns red. Up to 75% of people will have comorbid coronary artery disease, and that sometimes goes undiagnosed. Up to 64% of people will have at least mild cognitive impairment, and that increases the rate of institutionalization and also can lead to dementia. Many people will have MSK issues because of abnormal gait patterns. Up to 50% will have peripheral arterial disease, and that's a greater risk to mortality than stroke combined with coronary artery disease. Up to 77% of people will have abnormal blood glucose regulation, and that can more than double a patient's risk for repeat stroke. And people will lose up to 12% of the bone mineral density on the stroke-affected femur, and that's in the first year after a stroke. Normal loss with aging is 1% per year. So that, combined with balance deficits, can more than triple a patient's risk of sustaining a hip fracture, and that can be devastating. And a significant number of people will name fatigue as either the worst or one of the worst symptoms post-stroke, and it's very common. And depressive symptoms are also common. So a program of aerobic and resistance training, as well as the standard components of a cardiac rehab program, which includes psychosocial, nutrition, counseling, and risk factor modification and exercise, can help to address these issues. And I'll present some of that evidence a little bit later. Unfortunately, aerobic and resistance training components are often minimal or absent in traditional stroke rehabilitation programs, where it's been reported that people receive less than 3 minutes of exercise at an intensity required to improve cardiovascular fitness. And so it's not surprising that upon discharge, most patients become sedentary. Within 5 years, 20 to 30% will have a recurrent stroke. And at 5 years post-stroke, more people will die of heart disease than a repeat stroke. And that's why, in part, the American Heart and the American Stroke Association advocate that for individuals with disability after ischemic stroke, exercise supervision by a physical therapist or cardiac rehab professional may be considered. And also the Cardiac Care Network, in their published standards for the provision of cardiovascular rehab in Ontario, acknowledge the benefits that cardiac rehab can have for people following stroke, and state that cardiac rehab programs should be structured to attract and manage a wide spectrum of patient groups with vascular disease. So that provides some of the rationale and background for a TRREPS type of program. And for the next 10 minutes, I'm going to present to you I'm going to describe the TREPS program. I'm going to present to you some of the research that we've done examining the feasibility of exercise training for people with stroke, and present some of the physiological and cognitive outcomes of our program. And then I'll briefly describe the TREPS toolkit that we've created to help other programs operationalize a TREPS type of program. So first, the description. So over the years, we've developed an eligibility criteria to ensure that we receive appropriate referrals to our program. So patients to be referred to our program need to have an abnormal or hemiparetic gait pattern. They need to be able to ambulate at least 100 meters with or without a gait aid, with no severe limitations due to pain. They shouldn't be reliant on a wheelchair for day-to-day activities, and they should be able to carry out home exercise with or without assistance. And they should have completed their traditional stroke rehabilitation programs. Now, the higher functioning patients are streamed into our regular cardiac rehab program. Now, because of reports that only about 40% of eligible cardiac patients participate in a cardiac rehab program, we wanted to determine the proportion of stroke patients from a single traditional stroke rehab program who are eligible and participated in our program. So of 116 consecutively enrolled patients in a single outpatient program, 71% of those were eligible based on our criteria, and of those, 74% participated in our program. And we attributed that high rate of participation not only to the close association we had with the physiotherapists of the program, but also to the high level of motivation that these patients have to participate in an exercise program after their stroke rehab. So our TREPS program is similar in design to the traditional cardiac rehab program, where patients attend the center one time per week for 6 months, where they complete their individualized aerobic and resistance training programs. And the goal is to progress them to be able to do 30 to 60 minutes of aerobic exercise at the heart rate that was achieved at the anaerobic threshold on the exercise stress test. We also prescribe high-intensity interval training, as Paul mentioned, and you can see on the graph that shows the heart rate response from a patient who completed a HIT protocol about 3 weeks ago, and he had a 30% improvement in his cardiovascular fitness. And we've just received funding from the Heart&Stroke Foundation to examine the effects of HIT training. We also prescribe 1 to 2 sets of resistance training exercises at a weight load equivalent to 50 to 70% of 1 repetition maximum, or the heaviest weight the patient can lift one time. And we prescribe exercises that are functional and task specific, that require balance and coordination. And we progress patients by increasing the repetitions first, then we increase the weight load or resistance, and then we increase the velocity of movement, because increasing power or the rate of the muscle contraction may be more important for ADLs, or activities of daily living, than increasing absolute strength. We have a staff to patient ratio of 1 to 5, and patients are required to complete exercise diaries and hand them in weekly. And along with the standard components that I already mentioned of cardiac rehab, patients also receive 14 education sessions specific to stroke recovery. They also have cardiac exercise assessments and screening. Specifically, all patients will have a symptom-limited cardiopulmonary exercise test, or CPET for short. And in these tests, we collect and measure breath-by-breath expired air, we measure blood pressure, ECG, and we have the option of testing on a semi-recumbent cycle, upright, or a treadmill. And you can see we have adaptive pedals that secure the foot, or the foot and the leg, in place. And patients can actually purchase these and use them at home for their home exercise equipment. So that takes us to our first study, where we examined the feasibility of exercise training and cardiac rehab. So in this study, we examined the utility of the CPET for prescribing exercise to people post-stroke. We thought this warranted investigation, because although the American Heart Association recommends that an exercise test with ECG monitoring be conducted prior to starting an exercise program post-stroke, there's very little data to support this. And also because CPETs aren't routinely administered before starting an exercise program. So this means that patients are often prescribed exercise without an objective assessment of their functional capacity, blood pressure, symptoms, or ECG changes, which may be of concern because we know that they have a high risk of coexisting coronary artery disease with 20 to 40% having silent ischemia. Also, we now have compelling evidence that the intensity of exercise may be more important than the duration for reducing primary stroke risk and mortality in cardiac patients. So without a CPET, we may risk prescribing exercise that may be of suboptimal intensity or may precipitate a cardiovascular issue. So we analyzed CPET data from 98 consecutively enrolled TRI reps patients, and in a comparison group of 98 consecutively enrolled age and sex matched cardiac patients with no known stroke or TIA. And as an aside, 87% of the stroke patients completed the 6-month program, 70% of the cardiac patients completed the program. We have a very high completion rate with the stroke patients. So to determine the utility of the CPET for prescribing exercise, we determined that by the proportion of patients who reached a true physiological max on the test, because we often prescribe exercise based on a percentage of the peak heart rate or peak VO2 they attained. So if they didn't reach a max, we would be undertraining them. Or the proportion of patients who reached an anaerobic threshold, which is a gold standard intensity for prescribing exercise, or the proportion that developed a clinically relevant abnormality that would prevent exercise above the level where it occurred. So we found that the red bar on the far right, you'll see that 68.4% of all of the stroke patients achieved at least one of those criteria that we use for determining an exercise prescription, which was less than the cardiac, the blue bar. But more than 1 out of every 10 stroke patients developed a clinically relevant abnormality, and that was similar to the proportion of cardiac patients. So because most patients achieved a level of exertion sufficient to inform the prescription, and because we were able to identify any cardiac-related abnormalities, and there were no serious cardiac events with the CPET testing, we concluded that the data supported the utility and safety of CPETs for prescribing exercise. Now, establishing these target training intensities by CPET would be inconsequential if patients weren't able to reach those target training intensities systematically during a typical cardiac rehab session. So in our next study, we examined the ability of our patients to be able to reach those target intensities reported as eliciting health benefits during 30 minutes of aerobic training and 30 minutes of resistance training. So after the patient's 6 months CPET, we measured fasting resting metabolic rate so we could later report exercise intensity in METs or multiples of resting values. And then we measured oxygen uptake during 30 minutes of their most recently prescribed aerobic and 30 minutes of the most recently prescribed resistance training program. What we found was that the mean oxygen uptake during aerobic training, represented by the red bars, and resistance training, represented by the blue bar, fell within the target training intensity of 40 to 70% of VO2 peak, as recommended by the American Heart Association, and even exceeded that. And the mean time spent at 3 measured METs, or moderate to vigorous intensity exercise, was 30.8 minutes, which was similar to the target of 30 minutes recommended by the American College of Sports Medicine. Resistance training contributed 21% of that time. The mean energy expenditure during that full workout was 252 kilocalories, which was significantly greater than the ACSM recommendation of 200. Resistance training contributed 40% to that time. So we were able to demonstrate that patients with motor impairments were able to meet and even exceed the exercise training targets. And we also found that resistance training may be a good adjunct to aerobic training for providing an aerobic stimulus, which may be very important for patients who aren't able to cycle or walk fast enough to achieve aerobic benefit. So now I'm going to present you some of our outcomes. And in our next study, we measured the effects of the TRREPS program on multiple outcomes in 120 of our patients enrolled in the program. We're also interested in examining if the elapsed time from when the patient had the stroke to when they started the exercise program, if that had any effect on the outcome. And all of these patients started our program more than 6 months after their stroke, so past that point where you'd expect any spontaneous improvement to occur. So we had 4 primary outcomes, which included peak oxygen uptake measured by CPET, sit-to-stand performance, functional ambulation measured by the 6-minute walk test, and affected side knee extension strength. So what we found after we adjusted for our multiple comparisons, we had significant improvements in the 6-minute walk test, and these were all clinically relevant. Significant improvement in sit-to-stand performance, affected side knee extension strength, and we had a 16% improvement in cardiovascular fitness. And that's similar in magnitude to what we see with our cardiac patients. In our secondary outcomes, we found significant improvements in the anaerobic threshold, affected side elbow flexion and grip strength, affected side shoulder and hip flexion range of motion, as well as a significant improvement in balance. We also measured spatiotemporal changes in gait characteristics using a 5-meter pressure-sensitive mat, and we found significant improvements in walking velocity, non-affected and affected side step length, improvements in cadence, and improvements in health-related quality of life. There was a negative association between change in 6-minute walk distance and time from stroke after we adjusted for baseline levels. So we demonstrated that our adapted cardiac rehab program yields improvements over multiple domains of stroke recovery, but those who start earlier do have greater improvements in functional ambulation. So this would suggest that practitioners should adopt a seamless referral process to exercise programs from traditional stroke rehab. So the last study, we examined the effects of our program on cognition. And examining the effects of exercise on cognitive impairment is important because it's associated with a 3-fold increased risk of mortality, can lead to dementia, and it can lead to increased institutionalization rates. And we now have compelling evidence that regular physical activity can improve cognition and promote neurogenesis. And there's growing evidence that the type of exercise can play a role in optimizing brain health. For example, there were 2 meta-analyses that showed that the studies that included combined aerobic and resistance training had a greater effect size for improving cognition than the studies that only included aerobic training. And that was in healthy individuals. So we administered the Montreal Cognitive Assessment at baseline and following 6 months of training. We also measured body composition using a DEXA scan. What we found was that at baseline, 66% of our patients had at least mild cognitive impairment, and after 6 months of training, that proportion dropped to 37%. And we had qualitatively similar results when we used a different threshold score for mild cognitive impairment. Now, we also, in a linear regression model, we found that greater muscle mass accretion was associated with greater improvements in cognition and greater improvements in cardiovascular fitness, specifically the anaerobic threshold, was associated with greater improvements in attention and concentration. And that was after adjusting for a lot of the baseline levels. Oops. So we found significant improvement, a 44.5% reduction in the proportion of patients with at least mild cognitive impairment with aerobic and resistance training, which suggests that, and accretion of muscle mass had the potential for cognitive gain, suggests that resistance training with its anabolic component may be one of the key components to improve cognition. But larger randomized studies are required. And we actually just completed a randomized study and we're analyzing the data and that should be ready soon, hopefully. And now I'm just going to briefly describe a little bit about our TRX toolkit. And we developed it in the hopes that other programs would be able to operationalize a TRX type of program. And it's based on needs assessments and surveys from our patients and other healthcare practitioners, and feedback from our patients on our education sessions. And it's also based on our research and our experience and the available evidence. It will be available online and in print. And we have developed 14 education sessions which will be available on PowerPoint with a suggested script and handouts for patients. And we have 20 tools for the aerobic training section and 10 tools for the resistance training section with step-by-step guidelines of how to prescribe and progress exercise. We've got handouts for the patients where they should buy adapted pedals, etc. So we're hoping that this toolkit will help to improve the opportunities that patients have to access this type of program, but policies to incorporate these types of programs into the healthcare system are needed, and cardiac rehab programs are well positioned to fill this gap in the care of stroke survivors. So now I'm going to pass you over to Danielle for the fun part.
So thank you, Susan. Oh, I'm too short here. So hopefully it's a fun part. I'll try and make it nice and informative, and we'll stand up a little bit and do some exercise. But just as Dr. O had his little poll, I'm going to do the same thing. So what I'm going to be looking at next is what's best for our patients. Aerobic training, resistance training, or both. So a show of hands, who would say aerobic training only? Good, yeah, you're okay. Anyone for resistance training only? And for both? Oh, perfect. This is going to make my life a lot easier. So we all know that, and from what we discussed, Susan and Paul discussed before, is that generally most programs do have a combined aerobic and resistance training component when working with CAD patients. We've understood in terms of exercise prescription for the aerobic portion, in terms of guidelines and best practices, but what's becoming more clear over the last few years is in terms of the resistance training. So how much, how often, that type of dose response. So that's what I'll be looking at now. I'll be looking at a couple of studies, some that were done at our center and across the pond. And then again, we'll be looking at how you as practitioners can actually implement those resistance training programs to your patients and hopefully yourselves. So one of the studies that we have here, again, that was conducted at our center, looked at, more importantly, the dose response of resistance training. So we took 3 different groups, one who completed only aerobic training, one who completed aerobic training and resistance training, however they did 1 set of their resistance training, and then we had another group that looked at aerobic training plus the weight training, but they did 3 sets. So identified by the green, black, and red bars. And these were all patients, or all CAD patients. So what the chart depicts is the changes in lean body mass, changes in peak VO2, and changes in anaerobic threshold over a 29-week training period. That's how long that lasted for. So as you can see, we'll start with the one on the far left with the lean body mass. There was a progressively greater training effect across all groups, with that last group, the AT and RT for 3 sets, gaining close to 4 times the amount of lean tissue than the aerobic training group, which was significantly different and statistically different than the AT group. In terms of the VO2 peak, which is something that I found quite compelling, is all groups significantly improved their VO2 peak, and although there was no significant difference between their groups, there was a progressively relative improvement across the groups completing and increasing their VO2 from the AT group the AT+RT group with 1 set and the AT+RT group with three sets. But both AT groups, despite the fact that they completed 30% less amount of aerobic training, actually had higher increases in their VO2 peak. Looking at the last graph there, the last group, so the AT+RT 3-set group was the only one to have any type of significant difference. So as we can see, there is a response in terms of the resistance training, and the number of RT sessions we were able to find facilitated and optimizing that aerobic training response and increasing VO2, lean body mass, and those peak outcomes. Moving forward, looking at a meta-analysis, this was more looking at the combined, so doing aerobic training, resistance training versus aerobic training alone in those with coronary artery disease. Again, meta-analysis, different studies, again, some done on our home sites and all over. But collectively, the evidence suggests that resistance training and aerobic training is more effective than aerobic training alone. For example, when we look at peak workload, so for example, in the exercise test, there was an increase in the amount of peak work capacity that patients were able to do. When looking at strength of a bicep curl or a leg extension, there was increases in muscular strength for the group who did both the aerobic training and the resistance training. Moving forward, looking at lean body mass, fat mass, and trunk mass. We understand the importance of all of these elements, not only for activities of daily living, preventing falls, but also their effects on cardiovascular health and diabetes. Within the combined group of aerobic training and resistance training, participants were able to gain, in terms of lean mass, almost 1 kilogram. In terms of the fat mass, there was a loss of almost 2.5 kilograms. More importantly, more of that mass was coming from that trunk area, which we know the effects of that. So really great evidence showing the importance of both aerobic and resistance training in terms of treatment and standardization of care in terms of cardiac rehab, and the importance to include it when we're having those discussions with our patients about exercise modalities. So as Susan had said and Dr. O had said, at our program we provide a lot of education and training in terms of not only aerobic training but resistance training. Something that we have recently done is we've made it accessible to everyone. So our weight training program was recently put online to our cardiac college and our diabetes college, and there patients, clinicians, whoever would like to access that information can actually go onto those websites, look at the videos. There's phenomenal instructions, and they can pick and choose which videos they see fit that work with those individuals. So it's something that we're very, very happy that we've done. We've actually put some flyers and little leaflets just outside. So if you do want to take some, again, give those to your patients. We highly encourage that. But again, it's a great tool. It just shows how efficient and how easy and how you can do it in your home can be. So this is hopefully the fun part. So I want to show you, and we want to show you, how effective and how easy it can be to do some of these exercises. If you're consulting with a patient, they're at their home. So for you to do and say, you know what, I can do it here sitting in a chair, and so can you. So hopefully you all have a red exercise band. If not, we have some people, just put your hand up. We have Lisa who's passing some around. So what we'll do is we'll go through a couple of exercises, and we'll show you how efficient, how easy it can be. Yeah. And we have the wonderful Dr. O who will be demonstrating the exercises. All right. So the first exercise that we start with our program, it's a set of 10 exercises working major muscle groups from head to toe. So the first exercise that we're going to be doing is a dumbbell row. So we're working our upper back, scapular stabilization. So what you're going to do is actually we're all going to stand up, which is fun.
We need a band at the front, please.
So you're going to grab onto the ends of the band with your dominant hand. And with that same foot, you're going to put your band in between, just like Dr. O has, just in between the loop. Perfect. And generally we try and, we want to be safe, prevent any types of falls, watching for form. So with your opposite hand, you're going to actually grab on to the band with one hand. You're going to place your opposite hand just on a chair, on a table for support. Slightly leaning forward, you can have that opposite leg in front. I like to, when I'm coaching my patients, I like to think about with this one, is think about those old school lawnmowers. You know, the ones with the cords that you had to pull up? I know I'm not that young, but, so what you're gonna do is that motion. So you want to bring your elbow up towards the ceiling. You were doing dumbbell row, yeah, perfect. You're going to bring your elbow up towards the ceiling and slowly back down. In terms of the weight training, when we look at progression, we start with one set of 10 repetitions. So we'll do one arm 10 times, and then we'll switch to the opposite side. On that video at the Cardiac College and at the Diabetes College, we have descriptions in terms of how to progress, when is it time to progress, and also when is it time to not progress, some signs and symptoms to look out for, okay? Next one, it's a fun one, is the bicep curl. So you're going to step on the band, just as you were before, standing up nice and tall. You're going to grab onto the band with either arm, and with this one, we're going to do one arm at a time. So we're going to have our palms facing forward, elbows nice and close, and as Dr. O was showing us so beautifully, we're going to just lift the arm up, back down, and alternate. Exactly, breathing, relaxing the shoulders. So again, all of these things can be done with a band, a chair, in the comfort of someone's home, office, very easy to do and to use, okay? Looking at another upper body exercise, excuse me, we'll look at the tricep extension. So working the back of the arms there. So what you're going to do is, as Paul is doing, just grabbing onto the band just as so. That left hand, Dr. O is going to put nice and close to his chest. And that right arm, keeping it nice and close to his side, just straightening it down to his thigh and back up. Just as simple as that. 10 times on one side, and then 10 times on the other. We'll end off with one more exercise, looking at the muscles of the chest. With this one, again, still using the band, we're going to loop it around the back, have it underneath the elbows. It makes it a bit more comfortable. Keeping the shoulders relaxed and elbows out. Just a general chest press, so bringing the arms out and then back. Making sure to breathe, relax, never holding your breath. Perfect. Good job, everyone. You can sit down now and you keep the bands. So again, as demonstrated, we really encourage, and hopefully you understand the importance of both aerobic training and resistance training in terms of treatment and standardization of care for those living with CAD. And hopefully you realize, how accessible and how easy it can be for patients to do these exercises. Again, we encourage you, try them yourselves, try them at home. We'll look at now in terms of what it is in terms of your role for prescribing that. So thank you. On to Paul.
Terrific.
So wrapping this up, I think we're staying on time, Chris. We want to get you on the road, off to the malls to fight people for Christmas presents. So let's bring this together with what is your role. So we've talked a lot about background, why this is a bad thing in terms of populations, the benefits of doing these sorts of things for people with heart, thinking about new models for exercise, thinking about this whole untouched area of people living with stroke, bringing in not only the aerobic components, but the resistance components as well. What else can you do in your office kind of setting around assessment, counseling, and prescription? So, like any behavioral change, we recognize just telling somebody to go do something is not terribly effective. And in fact, there's good randomized trial information that would say, despite our best intentions, telling somebody to go exercise actually leads to less physical activity. Good randomized trial that showed that. People actually become 15 minutes less active just to spite you. And if you think of your interactions with your spouse, your mother-in-law, father-in-law, whoever it might be, you understand that tension. So we need to think about this a little bit differently. We could do half a day on motivational interview and counseling, or we could just distill out a few of these important things. So beyond telling people what to do, engaging with people, talking about what is important, why set goals or how to set goals, helping people to self-monitor, which is critically important. The people that are most successful, I think we heard from the weight control issues this morning, are those that track themselves. And that's one of the behavioral tools that Susan talked about in the context of stroke programs, cardiac programs, diabetes programs. That's one of the big things. Just write down what you are doing versus the own goals that you have actually set. A calendar may be the most powerful tool that you have. Of course, now we have apps to do these sorts of things. Think about social supports as well. You know, our programs are built around group exercise programs because people are strongly motivating of each other as well as interacting with fantastic health coaches. Writing things down, finally, might be really important. We're going to talk about that. And individualizing, as opposed to saying, let's get 30 minutes of activity for you in front of us today. What is important to you? And how might we do that? So 5 minutes might be the goal for the next week, 5 minutes a day, because that's still a step beyond sitting on the couch. And then bringing this into follow-up assessments, which is really critically important. We know that the majority of us in the room think that physical activity exercise is a good thing. We know that the majority of us ask about it. But we know also that the minority of Canadian physicians, and I've had the chance to do about 25 workshops across the country in the last 3 years, interacting with hundreds of docs. And this is kind of consistent stuff. So getting to the notion of actually writing something down is actually one step further, incrementally, and actually powerful, because endorsement by a healthcare practitioner is a strong motivator for success. So like we would write down a prescription, and I think I've told this story before, that we spend a lot of time thinking about the drugs that we write. And we would never write to the post-MI patient, here is some aspirin, good luck. Take it as you would, right? So we're very specific. Aspirin, 81 milligrams per day, every morning. Take it when you brush your teeth. If you have any stomach upset, if you see a black stool, well, please call me, because those are things that we're going to talk about. How often should I repeat this prescription? How often do I need to go back to the pharmacy, etc.? All of those things are critically important. And we need to do the same thing with exercise prescriptions. Walk 2 minutes or 2 kilometers in 30 minutes, 5 days per week. Use the resistance brands that you might actually give. Would this be something you'd want to incorporate into your practice because it costs $1 for that person? Or figure out how to do that. You could have a 50-yard roll of exercise band in your practice and just cut a piece off for every patient that might need it. Wow, what an interesting innovation. Use them 2 times a week, follow the videos, repeat this for life. Your caring doctor. The implication, of course, is if you don't do this, you don't care very much, do you? You might do this on your regular prescription pad because the patient expects a prescription as the outcome of the visit. You might even make use of tools that are actually available, and this is the Exercise Medicine prescription pad, for instance, that you can get there. And the specificity of the dose, duration, time is frequency, intensity, time, and type for exercise. And that's laid out right there, and you can rapidly circle. I'd like you to do walking 2 or 3 times per week at a light, moderate, or vigorous intensity for so many minutes. And then you can sign the bottom of this as a prescription. This is linked to the guidelines tools that are available at the Canadian Society for Exercise Physiology to build this discrepancy of where are you now versus where are guidelines kind of recommending, and how do you get there in terms of your own action plan. So these tools are available, and this is a blown-up version of those prescription pads. They're available in English and en français. On the reverse side of these prescriptions are actually counseling tips. What do we know about exercise? What do we mean by exercise? What do you mean by light or moderate or vigorous intensity? And actually can use that as counseling tools that you actually then hand over to the patient to take home so they actually remember a bit about that stuff. Make use of heart and stroke resources as well. And there's this great resource called Living Well with Heart Disease. We give out one of these to every one of the patients that comes to our program that highlights great information about what the condition is, eating well, and also getting active. So here's one more version of a stylized exercise program that's available to you. As we said, you can go to our own web platform and actually see this information as well about treating conditions, getting active, healthy eating, emotional well-being, and that is all available for free for anybody in the world. And then the final shot, we've talked a lot about tools, a lot about things that you're going to do with your patients. Those of you who've been with me before know that I like to show this slide. Because I get to fly around a lot, and during the flying around part, you're all familiar with this. This is the part that we all tune out on, right? But hearken back to when they actually describe the oxygen mask falling from the ceiling, and what do they tell you as a passenger? That who gets that first oxygen mask? You. What if there's a really cute child sitting next to you who's turning blue? Or what if there's somebody who's had an MI 6 months ago who is turning blue? Who gets the first oxygen mask? You do still, right? Because the notion is that if you don't do it yourself, then it's actually hard to transfer that. And there's actually good data about this as well. Physicians who are themselves very active find it much easier then naturally to start to prescribe this stuff. So you can be genuine about these kinds of activities. Lead by example, I think, is a wonderful opportunity. So in the last 15 seconds, Chris, physical inactivity is a key population risk, and we know that it contributes substantially to cardiovascular burden. Exercise has proven benefits in the prevention and management of chronic disease. It's safe and effective for people with heart disease, and sometimes that's one of the barriers that we have to get over. The summative parts of the evidence that we've discussed, aerobic training, 150 minutes at least. That's an arbitrary threshold. Some get more, some get less. Do the resistance training as well. The additive parts are really, really important. And sit less, no matter how much we do. Interval training is a new kind of approach here. As prescribed, find opportunities for your patients and for yourself. Thank you for sharing this session with us, and hopefully you've got some tools to take away.